So this is a short presentation on the lateral ankle ligaments and the instability associated with their damage. So let's focus on the anatomy first. We can see the two pins here with a focused view of the lateral ankle. And the first pin here that's under the cursor is identifying the fibula retinaculum, which can commonly become injured in a lateral ankle sprain. And what the fibula retinaculum does is it holds the fibular tendons as they course around the lateral malleolus and the brevis, which inserts into the base of the fifth, the longus, which courses under the foot and attaches medially at the base of the first metatarsal. It holds them against the calcaneus bones so they don't slip and bowstring. The lateral collateral ligaments of the ankle are broken into three parts. We can see two parts here. The anterior talofibular ligament, which courses from the fibula to the neck of the talus, and the calcaneofibular ligament, which courses from the fibula to the calcaneus. Note that the calcaneofibular ligament limits inversion at the ankle, and that the anterior talofibular ligament limits inversion and plantar flexion. Take a closer look at how the ATF functions. It's classic is we have this kind of high level study here, which is focusing in on doing tracings of the ankle joint. And you can see this kind of sagittal cross section here, which shows the tibia, talus, and calcaneus, and then the reconstruction from all those tracings, and then we get kind of a smooth looking set of bones, and then we can track how the bones move. And that's all produced by these this imaging setup here where the person's ankle is in a pit with the imaging monitors kind of capturing those shapes of their anatomy. And from this reconstruction we can produce of highly accurate movements of the subtalar joint and the ankle joint. So from that data, what did we learn? Well, classically the ATF, which is seen here in one of the images, is believed to only limit inversion and plantar flexion. But let's look at its alignment and see what else we learned from that data. We have the fibula here, and here's the talus. This is anterior and posterior. So if you look at the angulation of the anterior talofibular ligament, which is shown here between the white arrows, we can note that if it's ruptured, it's also going to limit internal rotation. So we can see that demonstrated in this picture here, where the talus is internally rotated, and what they're emphasizing in this picture is that's what can give you some pressure on the medial malleolus with the talus. And essentially, so the conclusion is the deficiency of the ATFL increases anterior translation, internal rotation, and inversion. And just to emphasize this, this is a coincidental recording of somebody who was getting motion analysis during a sidestep cutting maneuver, and during the maneuver with the instrumentation on their leg, they sprained their ankle. And so we can see here the data from the motion analysis during the ankle sprain. So this is the ground reaction forces. And we can see the dotted lines here are the normal ground reaction forces, and that's pretty normal for a sidestep cut where you have kind of a peak on landing, and then after you've absorbed the forces in the sidestep cut, then you kind of have a push off right around the peak here. You're going to push off toward the new direction, and these are in their vertical forces. Notice in the ankle sprain example, which is solid, they started fine, but then lost control or deviated from the normal patterns right here around 80, 90 milliseconds, and you can see there they didn't really push off. They kind of abandoned the cut. And so if we apply that point of assuming the ankle sprain is at the point where they deviated from their normal patterns, we could apply this same red marker the other angles at the ankle joint. And so here we have plantar flexion, dorsiflexion, where dorsiflexion is negative, plantar flexion is positive. And then here we have inversion, where inversion is positive. And then here we have internal rotation is positive. So if we just kind of look across these, we can see that at the point of the ankle sprain, the person here went into more, they had some plantar flexion here, and then right after the sprain, they kind of went into more dorsiflexion, followed by kind of plantar flexion here. They're going into a large amount of inversion at the point, I guess, they lost control. And here the amount of internal rotation is quite extreme. So we look back then, the first kind of thought was, well, maybe the injury is happening here. But then when you look at the data, what it suggests is that the loss of control happened maybe at 90 milliseconds, but the actual sprain probably occurs here more at 200 milliseconds, where all of the motions that would stretch the ATF are occurring. So right here at 200 milliseconds, we have our peak inversion, we also have our peak internal rotation, and we also are kind of really progressing into that plantar flexion position. So the injury likely occurred later, and the 90 millisecond point was the loss of control. So the injury here is occurring over more than 100 millisecond time frame. But that the clinical implications is, note that the injury or instability is associated with internal rotation as well as inversion and plantar flexion. Okay, so this is an interesting study because, especially for entry-level students, the assumption is that instability always correlates to symptoms or pain or functional problems. And it's just simply not the case, and it's repeatedly investigated and found at the knee, at the shoulder, and here at the ankle, that instability is not associated with function. So let's look at this data and see what we find out. So here, what they're doing is they're using a jig to cause a gapping at the talocrural joint. So here's the ankle joint, and instead of feeling for the gap, what they're doing in this case is they're causing this is an inversion moment, okay, by the jig. So they have like a 3-point contact, a point here, and then a point here. And so by causing this inversion moment, what they're doing is a medial talar tilt, essentially. And while they're doing that, they are taking an ultrasound probe and looking for gapping at the talocrural joint. So they're using the ultrasound to measure the amount of gapping at the joint level so they can get an accurate reading of the instability. And then here, they're doing it just another view in terms of that now they're doing it for anterior instability. So they're looking here for the tilt. So an inversion tilt with this inversion moment. And then here they're looking for an anterior instability. So you can see how the jig's set up now with this kind of distal bar posterior to the calcaneus. So basically they're seeing how far forward this jig moves the talus relative to the tibia. And so if you study this data, then what you notice is that they have in the one set here, they're looking at functional scales. So if you look here at the functional scales and then compare what they're calling copers and non-copers. So these are people who have instability, but from a functional perspective, they seem to do really well. And then people who have instability but don't seem to do well at all. And so one of the thoughts would be is that if you're a coper, your laxity would be less than a non-coper. So that would essentially would connect the idea of more laxity equals less functional level. But if you look at the amount of laxity that's occurring in these two charts, so if you look here, you'll see that the laxity levels are fairly even, and that the functional scales, despite that, the functional scales are quite different. So what it means is that laxity is not really different between copers and non-copers. And so that's our quick summary of laxity, how it occurs, and then functionally how it relates to our patient's symptoms after lateral ankle sprain.